asking that made a massive difference. That made me much more time efficient. I'll give an example of one of the cases I submitted. So my acute case was a clear cholecystitis. The patient came with...
Welcome to another success story. Today, I'm joined by Dr. Veeram Mahadea. Thanks for joining us today, Veeram, and congratulations again for passing the RCA. For people who might not know you, could you introduce yourself, please?
Yes, hi. My name is Veeram. I'm one of the GPSC3s currently working in Torbay in Southwest. And so I actually know Dr. Kwun from Mauritius, where I initially grew up, and I studied in Poland and did my foundation training in Thames Valley in Buckinghamshire and Frimley Health Trust prior to moving to the Southwest for my GP training.
Veeram and I, we knew each other from college. It was quite a long time ago now.
I was actually preparing for RCA, loads of stress, and then looking at videos, randomly typing titles in YouTube, and came across your channel and saw your work, and yeah, that's how I got back in touch with you and joined one of your courses. It was good.
For people who are preparing for their exams and want to know more about how to get started, what would you say you started with when you were preparing?
I started recording quite early on. I started recording videos just to get used to having videos recorded from ST2 when I was rotating in GP. And I think it's quite important to record, not just for the sake of the exam, but just to get used to it. And then sitting back during tutorials, for example, watching the videos, I learned quite a lot about myself and my interview techniques. So in a way, once it got to preparing more for the exam, so I was a bit more comfortable with the aspect of videoing itself. So it was more a question of getting the timing right, getting the right cases, not missing things. And that's where different courses, different resources became more important to me. So for me to start recording for the exam, I had been recording for a while. So many of my recordings, I'll give an example. So of the title, so HRT was one of my cases for the exam. I probably did like 7 or 8 consultations about HRT, and it's only the last 2 probably that were, in my opinion, worth submitting, and I submitted one of them. But ultimately, you need to be organized. I think organization is one of the main things here. So before I was recording on the webcam on the screen, and then later on, I think you mentioned that as well in terms in one of your videos on YouTube in terms of the structure of the exam and how to do the recording and so on. And you mentioned that doing the recording on your app on the phone doesn't use up your minutes in video consults. So at that point, I spoke with my supervisor at the GP surgery, and she was really supportive. The GP surgery bought 2 phone stands for our 2 sites and in my offices. So I had the luxury of having the app and using 3 minutes in a way to record. So I could have loads of recordings, and I barely used up any minutes. Most of my minutes used were from my telephone consults. So that's one thing. So having a good camera, good setup in the room to know where you're going to be recording, that's one thing, because that was always a bit stressful. What if this part of the body is showing? What if that part of the body is showing? Am I seeing enough of myself? Is enough of the patient being seen? So all of that bit, that's a little bit stressful, actually makes a lot of difference once you've nailed that these little details. Then you can focus on the recordings themselves and the content of them to get that narrowed into those 12 minutes. I think that's getting all of these little details set up was quite important, and took a lot, in a way, a lot of stress for me, because I was always asking myself and my supervisor, do you think this is enough? Do you think this is good in terms of video. So once I get it for the exam, do you think that setup is okay? So these details, I think were quite important in the first instance. And then once I started looking more at the recordings themselves, then, as I was explaining earlier, how I came into contact with your channel, I was looking at case examples because we know the mandatory cases to submit. So I was looking at the mandatory cases, and then you get that stress again about how do you find the right case, which one's the right case. So there was a lot of checking online and YouTube and different platforms which cases have people submitted, so success stories. So your success stories, I've watched a few of them to try to get a better idea of where do I start. So one of the cases I submitted was tonsillitis. Everyone would think, oh, it's just an upper respiratory tract infection. It's a bit too simple, isn't it? But then the tonsillitis was slightly more meaty because it was a recurrent tonsillitis. I went over aspects of tonsillectomy, so to get more out of a slightly simple case, so to make it more complex, and it worked. So organization first, and then finding the right cases you want to video. So some things you need to get comfortable with. So women's health, I was never comfortable with. Watched one of the teachings on 14 fish about it, and luckily I was lucky enough to be on your cohort when we did the case, and you did a case of a women's health, and a couple of questions I had before were answered during that case. So when it came to my recording of the women's health, I was a lot more comfortable with women's health itself. So knowing what you want to record and learning about it beforehand makes it easier. So I had 4 or 5 videos or remote telephone consults about HRT, which is one of my recordings for the exam. They were like 20 minutes long, 18 minutes long, and looking back, I was like, how can I make it shorter? How can I make it more concise? How can I fit it into that 12 minutes? At that point, you think, it's a massive topic. I can't fit that into one consult. Clearly, it needs to go into 2 consults. So you need to plan it. What do I need to tell the patient so that it has all the relevant information and it can go on into a second consult with a clear plan, a follow-up plan in place, a safety net in place to make it good for the exam. And that's how I managed to narrow these down. And I, I don't know if I should be saying this, but you were really good in terms of support. I had loads of questions for you. I would message you, asking, do you think this case would be good? Do you think that would be good? I was just generally asking about example of cases before seeing a patient. I was like asking people, I've never done the exam, and you were there. You've done it. You've supported people through it, and I you were kind enough to help me.
Sometimes it's very confusing for registrars to know whether this would be a good case or not. We work through, as in during the course, with the role plays, and then that answered your questions. Tell us, how did you manage your time then? Because this is a really major challenge that many registrars have. Keep up with the 12 minutes.
I think one of the big things that made me save quite a few minutes was asking the ICE early on. So giving 1 or 2 golden minutes at most, and then asking the ICE quite early on. I think for me that's the main thing that made me much more time efficient. I remember cases as an ST2 that at the end my supervisor was asking what was their ICE, and then I was thinking back, looking, oh, I've watched the video now. I didn't actually ask them what their ICE was, but I was assuming, I was deducing from making deductions from what they have said, rather than straightforward question, what's your eyes? What was your eye? What do you think is going on? Anything else worrying you? What were you hoping to get out of today's consult? And actually asking that made a massive, massive difference.
What did you find were really useful when you were preparing your cases before starting the consultation?
Looking, we use EMIS as computer systems, so going through EMIS, going through latest document, going through the latest consults, see what the main issue was, the problem the patient was coming with, had that been dealt with before, had similar problems happened before, was that investigated, were any other referrals made before, and then general knowledge about the patient. So ask, just using the search box on Emix, checking smoking, checking alcohol, and then when the patient was in, I was like, okay, I gather you smoke 10 cigarettes a day. Is that still the case? Rather than asking the question from scratch. In that way, the examiner knows you know the patient, you've done your research about the patient, and you're not doing history taking for much longer. So it's actually building better rapport when it comes to that. So doing your research about the patient is one, and then secondly, have a working diagnosis in your head. Very often, looking at the duty triage list, you have a rough idea of what it can be. So reading a bit about it, just the up-to-date guidelines, the management. So do you need to investigate with this? Do you need to give this medication or that medication? How do you follow up? So just having the management plan for the most likely working diagnosis was the second thing I found quite useful.
I see oftentimes when registrars don't prep their cases very well, then they're stuck in data gathering and they take longer because they're having to think it through. Whereas if you've done that thinking beforehand, then when you take your history, it's more sleek and you know what you need to ask.
Mm-hmm.
So with the clinical management, were there any strategies or techniques that you found very useful to manage your patient?
Yes, I'll give an example of one of the cases I submitted. So my acute case was a clear cholecystitis. The patient came with so epigastric, right upper quadrant pain, temperature, not feeling quite well. So from reading the triage, I was like, oh, that's probably gonna end the patient in hospital. So speaking with the patient, when I mentioned the diagnosis, what I thought it was, I tried to make it, as you told me before, make it a shared management plan, not a doctor-centered management plan. So we know the patient has to go to hospital, but we need to make it a shared management plan. So I asked the question, what do you think if I were to tell you how to go to hospital because of this problem? Have you given it a thought? Do you have arrangements in place if we were to go to hospital in terms of childcare and so on? So patient-centered and doctor-centered. So making a management plan together was quite important, and that was something I didn't do before. It became more natural following prepping for RCA.
So yeah, having this empathy and demonstrating that you are thoughtful in your plan so that it's fitting to your patient's need, that's really important. And that's what separates people who don't do well and those who do well in clinical management. The other thing is how much time did you have for your clinical management, Viram?
I don't know if that's right or wrong because everyone says you take about 6 minutes for focus history and an exam, and then you have a remaining 6 minutes to discuss clinical management and follow-up plan and safety netting. I don't know if that's right or wrong. I didn't score too highly. I passed. I got over, I think, just above the average, which is probably why I didn't score much higher than that, was because my data gathering and physical exam took me more than 6 minutes. It was closer to 7.5 minutes, and my management and follow-up safety net plan took less time, to work closer to 4 minutes rather than 6 as would be recommended.
Did you find that you were rushing it towards the end, or did you manage to wrap your management plan?
Yeah, I think the management plan for me was not a problem because normally when I summarize, I tell the patient what I think it probably is, and then let me examine you just to confirm or disprove some things, and then I manage. As I was saying, this is the most likely problem here, and then we discuss that bit. For me, the trickier bit was not the clinical management, but was to fit the follow-up and safety netting at the end into the 12 minutes. That's what was more challenging for me.
Right. Could you share your marks to the audience? So you still had a margin
Mhm,
above the pass mark. When you were selecting your cases before submission,
mhm.
how did you select the cases for submission, and what was the process of marking these cases, Viram?
After doing a consult, I think that was a good one. So for me, the first impression of the case was quite important, and then I watched the video once later. At that point, I thought, I still think it's a good one. There's nothing that hit, sometimes you do a video and you think, oh, I forgot to ask this. And that's definitely not not a good video. And the videos I found, I submitted were videos where I didn't have that thought at the end after having watched it 2 times.
So yeah, when you know already that you've done something that's not right,
Hmm.
then it's very obvious for the examiner to pick that up. So it's not
Yeah.
one that you want to submit. You won't submit one that's showcasing your best capabilities. Then when it came to the submission, then what did you do for writing it down in terms of the workbook? Because a lot of registrars are not sure how to write it.
I was quite brief. I wasn't sure, as you're saying, I wasn't sure how much I had to write in it. So what I was submitting was 2 cases from each mandatory criteria and one extra one. So I essentially put the title, so for the workbook, to show which case it was, and then um, linked it to that criteria. So for example, my over 65 case was actually more of a bereavement mental health case, but the lady was over 65. So in the workbook, I did put it there. So 65 or 66 years old, bereavement. And then I mentioned discussed sedation and risks of falls. So in that example, that would show that it is a 65 plus because you're thinking of aspects of falling in the elderly population. Um, so yeah, my titles were quite brief to just to show the mandatory criteria.
Ideally, you want to keep it brief because examiners don't have much time to go over reading these. And usually, these are mainly for descriptive purposes, and you won't get any marks for this. So don't waste too much time on them. As we're
Yeah,
going through the mandatory case selection, then, so that was your elderly case. Can you tell us
yeah.
what were the other mandatory cases you submitted, Viram?
Reproductive health and women's health. So I submitted an HRT case, and the second case I submitted was a penile lesion with a gentleman who had itchiness and soreness, which sounded pretty much like fungal infection, but then there was the aspect of erectile dysfunction in his case, so he had to discuss diabetes screening. So that that all came together, and I put that in my reproductive reproductive case. For mental health, I had so two cases. One was more general anxiety, and the other one was depressed mood, if I remember right. Yeah, so low mood and anxiety, depression. So more of a general anxiety was one of the cases. And then, so over 65, I had the bereavement, and then I had a COPD, which was my RESP. I had a pediatric asthma and a child migraine. I had that tonsillitis case I mentioned. I had a perineal abscess and a cholecystitis, a pericarditis case. Yeah, and yeah, that was it.
Was it something that you did telephone or face-to-face, the perineal abscess?
The perineal abscess was a video. So the phone calls I did were the 2 mental health one and the HRT.
It looks like you have got a breadth of cases, and some of the cases you had were quite interesting. So, were you thinking about the complexity and the challenge when you were submitting them?
Some cases, when I was preparing for them, I thought, how could they become a good case for the RCA? So the tonsillitis case, as I mentioned before, I considered the aspect of tonsillectomy and recurrent tonsillitis to see whether I could make it into an RCA case. So preparing in advance for the case from the triage notes, um, that was one of them. Couple of cases. So in my GP surgery, I'm quite lucky because I do duty list on Mondays and Fridays. So for me, I could cherry pick a bit more when it came to the list and bringing people to see me in the surgery. So when I saw a quick triage question, HRT, I was like, okay, I'll take that one. I let the staff know that I want to get my HRT consult done by the end of next week, so I can forget about it and stop worrying about it. So for a couple of weeks, I had loads of HRT cases, so I could prep better for them. If you do them more often, you get more comfortable with them, and little mistakes you were doing before, you tend not to do. So that way of prepping and that case was fine. And the COPD case was a good one, but I didn't feel like it was complex enough initially. And then speaking with the patient, he mentioned leg swelling, for example. So that's when I started to get a little bit into the heart failure side and discussed doing a pro BNP test and so on, to check to screen for heart failure. And that's how some cases that initially sounded slightly simple became a bit more interesting. But doing videos, recording the videos at that stage, I was thinking of cases that, okay, this can be a good one in 12 minutes. I will get the consent for it and I will tell them that I'm going to be recording for the exam. And then at the end, if they turned out to be good cases, then great. So some of them I did specifically for the exam, like the HRT ones, but some of them I recorded hoping they would be good.
Looking back, what were the things that you would have done differently, Viram?
A difficult question because I passed, so I try not to think about it. Um, I'm not sure. I'm not sure. I don't know. Looking at my scoring. So in terms of comments, there's a comment about 2 times that was mentioned about not eliciting enough new information. So looking at that and then thinking back, I was like, maybe my golden extra minute I gave them, maybe that was too much. Maybe I should have interrupted a bit earlier and asked a bit more questions to show that I'm eliciting information. It's difficult to say in retrospect, isn't it? But I can only base it based on what they have, based on some comments here. But some of the comments there, I'm not sure. Like, for example, it says insufficient evidence of interpersonal skills demonstrated, and and thinking back about my videos, I'm not sure how that was demonstrated, or how I would have improved that, because um, my patient feedback and my colleague feedback has been okay. So it is difficult in retrospect.
It is difficult, I
I'm
agree
not
with you.
sure how to answer that question, sorry.
Let me ask you a different question. Where were you spending a lot of time that, in retrospect, you think was a waste of your time? Or what could you have done that would have been more effective?
So before I had the stand, before I was a bit more structured in terms of reading about the patient a bit more, I had cases where I thought, oh yeah, I'm going to record for the exam and just come there, get their consent, and then start recording. And clearly was not the right strategy and approach to record. And these videos were never going to be good enough. So some friends, some colleagues have been talking about video recording burnout. That you're recording so much that you're feeling just fed up of recording. Maybe I recorded a bit too much at one point, and without much prepping. And these cases, I could have just not recorded. So it's better to record less, but properly preparing for them with a good strategy and mindset rather than just trying to get the numbers up.
That's a really important point that you've raised, because there is really a fatigue when you keep recording for the RCA, because it's very depleting. And sometimes you need to take rest, and don't just record blindly and keep recording. It's very important to be intentional. And when you're recording, aim for quality, not just for quantity.
Absolutely.
If you had to give advice to somebody who's going to sit the exam soon, what would you say to that person?
So I would tell that person to look at the mandatory criteria and try to take the cases, try to do them as they come in those criteria. So if you want to focus on women's health, try to get that video done before moving to the next one, unless a very clear one has come through. But if you are doing, as I was doing, duty list, for example, and the surgery is aware that you're doing it for the exam and they're happy for you to cherry pick, then I wouldn't be cherry picking. Oh, there's a COPD, I can do that. Oh, there's an HRT, I can do that. There's a there's a possible heart attack, I'll do that one as well, and record all of them. I think that makes it a bit messy, and it makes it difficult for you to switch from one to the other for the case of the RCA. So I think preparing for each one separately is probably a good idea if you can afford to do that.
That's a good point. Yeah. If you can focus your clinic and try to get similar cases on the same day, that'll give you a higher chance of getting a good recording rather than doing a knee problem, an elbow problem, and then a pediatric case. So if you focus on the same theme of the mandatory case selection, that would help you to get better recording. So thank you very much for taking the time
All right.
to share your story and experience. So what's your plan next, Viram?
Yeah, so CCT end of July, beginning of August, and then probably a salaried job to start off with, because I have two younger children, so I don't want to not know when I work, when I'm working, when I'm not working, if I'm getting, if I get poorly and get sick, about, salaries and so on. So for me, a salaried job in the first instance would be what I'd be looking for. Yeah.
Great. So thank you very much for watching up until the end. If you've got any questions, please write it down in the comment section. Are you struggling with your consultation skills? Maybe you need help and you want to get constructive feedback. If you'd like to get help, then I'd recommend that you click the link down in the description below to book a free call to see whether we can work together on a one-on-one coaching program. If I think that I can help you, then we can get you on the coaching program. But if I can't help you, then at least you get some insights.